There's been a long-standing interest in bisphosphonates. We know that bisphosphonates inhibit osteoclast and inhibit bone turnover and are effective for osteoporosis and also effective for lowering the complication rate in patients with bone metastases. And it has been hypothesized that because of its effect on bone turnover and the fact that we know the bone can be a site for micrometastases, which may be a staging ground for other metastases, that maybe by making the bone less hospitable to support micrometastases with drugs like bisphosphonates that inhibit bone turnover, that we may actually see an adjuvant benefit that when given to patients with early stage breast cancer may prevent recurrences. And that was actually seen with some of the lower potency bisphosphonates such as clodronate in studies, but in order to replicate these in large studies and also with the more effective amino bisphosphonates that are much more potent, several trials have been undertaken over the last few years. The drug most represented is zoledronate, and studies with that drug have been mixed. The results have generally been negative, but when looking at the results in postmenopausal patients or patients who are receiving ovarian blockade, there does seem to be a benefit. The ABCSG12, which was for premenopausal women, but all of whom had gonadotropin analogs to shut the ovaries down, did show a benefit with zoledronate. The more recent Azure study, however, did not. But upon looking at that retrospectively with patients who were clearly postmenopausal, they did seem to benefit. So we were caught in this situation where the trials were not consistent, and an overview analysis was done by Robert Coleman, and this was presented at San Antonio, where over 22,000 patients now from multiple trials were looked at with the individual data available from each of these trials. And what that showed is a clear improvement in outcome, particularly in postmenopausal patients in terms of metastatic disease, particularly really confined to bone metastases, which of course is the most common site of metastases. And that translated into an improved survival. And again, that was really mostly seen in the postmenopausal group of women. So the big question now is, how do we interpret that data? Normally we go by single studies that are positive or several studies that are positive. But when the studies themselves aren't positive uniformly, but a meta-analysis is, how are we going to react to that? And particularly for postmenopausal patients. And the benefits that we are seeing in these patients in terms of mortality is in the range of what we might see with adjuvant chemotherapy. So I think this is something that the professional community is going to need to deliberate over. ASCO's last set of guidelines several years ago obviously did not recommend it. Of course, we didn't have the data then. So it'll be interesting to see what the recommendations, which I believe are going to be out shortly, are going to say with the new data.